Recognize Mr. Griffith of Virginia for 5 minutes.
Thank you very much. I appreciate that. I'll let any of you jump in on this. One of the things that we haven't discussed in detail, but is a part of that and I'm not going to pronounce the word right, but multi-reasons why someone might commit suicide. I noticed an article that I read indicated that there are families who suffer from depression who have multiple members who have committed suicide, and other families who suffer with a history of depression who do not have suicide, not a single one. And I'm wondering what the thoughts are. Do you all believe, and everybody can answer this, do you believe that there is a gene that we might be able to identify that would say these folks with depression are more likely to commit suicide than other folks? And do we target or do we put special attention on those who have a family history both of the mental illness of depression and a resulting suicidal act in the family?
Go ahead, David.
And I'll start, and then we can open up to the panel. Certainly there are genetic influences on a variety of conditions. Substance use, abuse of substances. Alcoholism obviously has a genetic predisposition. There are also mental health disorders, severe mental health disorders that do have a genetic genetic connection there as well. We know a definite risk factor is having a family member who has committed suicide. We know that is a risk factor. And the whole idea of genetics and its tie-in with suicide, I think, is still to be determined, I think, in our research world. And I'll pass the microphone on to the clinicians here to further give their opinion on this.
Well, there's definitely a genetic influence to suicide. And the families that you were describing, the two types of families, is strong evidence for that. But that doesn't mean that it's caused by a single gene. And I think that when we deal with families where there has been a completed suicide, we have to tell people actually that you are at increased genetic risk, but genetics isn't destiny. If you have a risk that's 40 per 100,000 instead of 10 per 100,000, the odds are still with you. And so I think it's important not to oversell that. At the same time, we are chasing what might be some genetic factors that could be contributing to suicide risk, but it's not going to be one gene.
I would just add that looking at this through a public health lens, it's very easy to identify the people who are deserving of extra attention, who is at higher risk. People who have tried before, people who have close family members who have killed themselves. So we don't lack for an ability to identify the at-risk population.
Did you want to add anything?
Well, I think I'll just say it's as you heard, we have things that we can implement now. Research is fine and good, but if it doesn't translate into something that's actionable to actually help people, I think in many cases what you're hearing is that we have evidence-based strategies, and now we have growing access to care. Now we have to link the two. So I think there are things that we need to do now, and continuing and to more robustly fund research is very important. We're probably some years away from that genetic answer for predicting suicide risk, but it could be there, absolutely.
Well, I appreciate that and hope that while I know that it's just one piece of the puzzle, I would hope that the researchers and both private and governmental areas would continue to look into that. Switching gears, I would ask the Surgeon General if he could comment on the possibility of using the U.S. Air Force Suicide Prevention Program as a possible model for the other branches, because obviously we are all concerned with the high increase in the large numbers of our armed forces who return from combat.
Certainly, I think it's a discussion that I can certainly have and will have with the other surgeons generals of both the Army, of the Army, Navy, as well as the Air Force, my fellow surgeons, if you will. That being said, I think the Air Force is a great model. The Air Force has two components to their program. One component is the wingman component, which is a serviceman watching out for other servicemen. The other component is actually built into a youth prevention program. I think the bottom line to all of this, and it really goes back to this public health model that I described earlier, ultimately we're looking for what works. Part of what works is to be able to look at innovations, look at changes, and properly evaluate them. Because ultimately, as we go further to implement this, whether it's across the armed services or whether it's across the nation, I have to have proven systems that work before nationwide implementation goes. But I think we're on that pathway to find out what's working and to see how it's implementable, even in terms of further pilot studies.
And Mr. Chairman, if you all will indulge me, I'm going to go back to the first question because something came to my mind. One of the factors is also substance abuse, and I'm wondering if there are any programs out there. We talked earlier about educating people on what you might do and why television, we've learned, you know, everybody should use deodorant, but we haven't learned how to deal with suicide. For those families that have a history of both substance abuse and suicide, I wonder how much work is being done on encouraging those families to be abstinent when it comes to both alcohol and other substances.
I think certainly when we look at all the risk factors, and I think we sort of described it earlier, is we know a lot of the risk factors that exist out there. Now, how all these are bundled together, which is the family history component in addition to the substance use or abuse component, we certainly look and try to strengthen our specific prevention activities within those populations. But in essence is we sometimes break them apart. In other words, the substance use is treated differently than the family history one. But I'll turn to the clinicians here who do this on a daily basis.
So substance abuse prevention is an interesting issue because it's so prevalent, especially in adolescents and young adults, that there's argument that a universal prevention actually makes more sense than targeting people that are at high risk. And in that policy institute I mentioned, the Washington State Policy Institute, they've identified several intervention programs that are low cost, that are relatively brief, that have shown to reduce substance abuse by about 1/3 in communities where it's been implemented.
And the gentleman's time has expired, but if you could get us copies of, anytime any of you reference any study, I hope you'll get us copies of things. That's valuable.
Thank you, Mr. Chairman. I appreciate the committee's indulgence.
Thank you. Now, Ms. Castor, recognized for 5 minutes.